organizations have to increase rates by 7%. And then the fee for service side also increases rates by 7%. So it's like a directed 7% increase. And then on the back end, what healthcare authority has to do is we have to work with our Medicaid, CMS, our federal partner, and essentially do what is called a state directed payment. And that is where we show that there are quality metrics that support, we have to show that the rate increase is actually doing some sort of improvement in certain performance metrics. And so just so you guys know, CMS is getting more strict on that. Like before, the state directed payment was kind of easy to do, honestly. And so we didn't really think anything of it. So the last couple of years, all the BHAs have received like a 7% increase and a 15% increase in the last couple of years. And now CMS put out stricter requirements around that. And it's a little too early to know how hard it will be to do more state directed payments in the future. Like it's a new rule and we're kind of learning, and we're going to start socializing the new rule with the advocates and the providers and our legislator folks, our ledge folks. But that's kind of a new thing that's just popped up recently.
What does that mean that CMS is making stricter requirements?
Yeah, so the state can't just arbitrarily raise the rates. Like we have to have some support behind that. And then what we have to show is that we have to show that quality, some sort of quality service, increase in quality, increase in metrics will occur because we've infused the system with more money. So for example, one of the metrics we look at in Medicaid is follow-up after emergency department visits. If we infuse the outpatient service providers with more money, the thinking is that they'll be able to get more people in and see people more quickly. And so that follow-up measure should improve. And that's like an example. And so essentially CMS is not giving states carte blanche ability to just raise rates. We have to tie those rate increases to tangible improvement in certain metrics. And if we can't, we may lose the ability to keep that rate increase. That's the concern. Or we may lose the ability to do a future increase because we weren't able to show that the previous increase actually did anything. Does that make sense?
Yeah. So the caution is to not ask for more than what we can prove will be sustainable.
I think the caution, yeah, I mean, I think the caution is that we have to have some sort of confidence that the rate increases are actually that's actually going to bolster more access, better quality of services or something, right? So, and that's part of what's hard is that when we do these rate increases, I have no control at the state level as to what a certain agency does with that rate increase. Does that make sense? Like they could get that increase and then maybe never raise wages for their staff. Or maybe I have no control over that.
There's no way to put that in there, that this money is definitely for the staff wage increases.
So that would be maybe something to think about and how you would recommend it. I don't know exactly how we would do it, but typically, because we're not the one contracting with agencies.
Right.
Right. So that is one of the challenges with these rate increases in Medicaid. They could go to anything.
Yeah.
That makes sense, but if you look at your room and board reimbursement rate is only $14.20 per day. That doesn't even pay for one meal for one person at today's cost of food. I mean, I go to Burger King and I pay
Yeah.
$14.20. So to me, I definitely hear what you're saying. I just don't know how, I mean, we could back that up when, I mean, you look at the number and you know that that's overly
Yeah. So,
under represented.
yep. So Alicia, room and board is not Medicaid. So room and board is paid solely by general fund state dollars, and this is definitely one that could have a proviso attached, increasing that amount. That is definitely one that we could put forward as a recommendation. So that's not Medicaid won't pay for room and board. It's 100% state funded. And just so you guys know, we've tried to do a decision packet the last couple years to get this increased, and we can't get it across the finish line because OFM and lead shoots it down. So this is definitely one
Yeah.
that is easy to do. Not
I mean, I know
easy.
they've increased it like $1 over the last 3 years, but it's
Yeah.
still 14.20. It's
Woohoo, a
just a
dollar.
crazy amount.
Mhm.
And
Yeah.
where's who came up with this number? Median salary is 77,000, approximately $34 an hour. That's I make 73,000 in a year, and my wage is $35 an hour. So those numbers are not accurate.
Yeah,
I
I
think
don't
that's across the
know.
state. I think Western Washington probably makes a little bit more than Eastern Washington, would
That's
be
the
my
thing is
guess.
I don't know who loaded all the information. That's one of the things.
Oh,
So one of the comments, like I don't know if I can do this. Yeah, see if I can do this.
median salary, I guess they're probably from two different sources, those numbers. Like the median salary, you know, across the state is the middle range, $77,000. And then they guesstimated $34 an hour because 77,000 would be about $37, $7 an hour, something like that. Oh,
Yeah,
good. Okay.
there's two main sources we tend to go to. Bureau of Labor and Statistics, BLS data. And then the other source that we've been using is the Milliman study that was
Do you
done.
think it really matters? I mean, are those numbers, is it worth our time to, quibble about that? It probably doesn't really
I
matter.
think it was just a point into why we are recommending
Uh,
higher reimbursement rates is because of that rate.
a guideline for reimbursement. Yeah.
Yeah.
Okay. Okay. Accuracy is so important to me, and I just focus on that, and I apologize. It's probably not necessary.
I think part of it was to justify, if this is my theory, I don't know if it's true, but part of the goal of the work group is to increase access to care. But if we can't increase access to care because we can't pay for a living wage, then
People don't want to
then
stay
it
in that
becomes
job.
right. And if
Right.
we don't have reimbursement rates that can pay for this median salary, then employers are not going to be able to hire the staff in order to accommodate the increase in assessments and the increase in intakes and the increase in all these other things that are required in order to give better access to care and reduce barriers. That was my thought.
Yeah, good.
Just showing that, hey, we can make all these recommendations for how to reduce barriers, but if we don't have the staff in order to accommodate it because we can't afford to pay them, then it's a moot point. That's where I'm coming from anyway.
So, yeah, I think that needs to be clear in here. I don't know if so again, I don't know if you guys want to kind of start with the nugget of the recommendations and then go back up, kind of go back through and kind of like hone in on what it is we'd want to see increased.
Um, and I don't know what this acute detox settings 3.7, I don't remember what that was put in there for.
Well, I think so. My understanding is that I think when this was talked about, I think some folks were saying, that level of care was really too low. I mean, that was getting paid too low. 3.7 is going to go through a pretty big overhaul with the ASAM 4. And so I think that the increase will need to happen anyway. But I think we could double down. I mean, one of the recommendations, could be just to ensure that that level of care receives an adequate rate increase to meet the program requirements of the updated ASAM.
Yeah, I'm not even sure if 3.7 is gonna be available anymore. I think it's changing.
It is. It's 3.7. There'll be 3.7, 3.7 co-occurring enhanced, and 3.7 biometrical something. So there's like couple different levels with 3.7.
Right.
So are they, in this work group, are they asking us to come up with a guideline for what those reimbursement rates should be? Is that what is going to be delivered to the legislative board? I mean, because I have no idea what the reimbursement rates should be. But my fear is if we don't have like a guideline, then they could say, okay, yeah, you're right, 14.20 is a pretty low rate, so we're going to increase it to $15.20. Or am I overthinking it?
No, I don't think you're overthinking. So with room and board, I mean, we could recommend a pathway, reviewing other states to determine, what other states are doing for room and board. You could recommend a pathway and maybe also like something like clear understanding what room and board covers and what it doesn't.
I like that.
Are you typing currently, Alicia? Because it's not really, it's
Is it not?
okay.
Is it not showing?
It's not showing it's because I think I'm frozen a little bit, so.
I went up to edit.
It's because my screen is frozen, like I can't see it. So you're
Okay.
probably fine. It's just that it's not.
Well, I don't know. It's saying not syncing, so maybe it's me. Beth, can you see the changes that are being made?
No, I'm not seeing anything right now. I'm seeing a blank screen, but I was seeing the changes. It was nice. It was in
Oh,
green.
okay.
Yeah, I was seeing
Oh,
it.
so it is racist. Okay.
Looks like it's loading. Here we go. Here we go. Oh, now it's red. Okay, beautiful.
I mean, just to give you guys, I think we looked at like Montana, and Montana was paying like $50 a day. We were like,
Oh my goodness.
oh, it's a little.
Okay. Um, is it possible to put in here? I mean, I know that we can encourage Medicaid, but is there any room for like contracts with private insurance? Is that something that there's any room to have like a minimum standard of what private insurance can contract with behavioral health agencies? I know there's a private insurance that reimburses IOP for like $74 a session, which is crazy low. Or and level one is like $26 a session or something.
You could do something like, you know, uh, maybe a recommendation, that, um, that the Office of the Insurance Commissioner, so OIC is who oversees private. So the office, so recommendation, the office, OIC, um,
Examines
mhm,
contracted contracted rates with behavioral health providers.
mhm.
To ensure like equitable reimbursement rates or something.
Mhm.
That sound okay?
Mhm. It's all drafty draft.
And the proposed recommendation, is that something that we pull? I know that there was some discussion last time about this cannabis tax revenue going into the general fund. I don't know if that's something that anybody's researched to see if that's true, or I don't know enough about it. but is that something that we would pull into the recommendations for ensuring that the cannabis tax revenue is going directly to behavioral health environment and providers?
Yeah, I mean, that could be, so it's up here, you know, there's a question, could taxes from alcohol or are you talking about the taxes or something else?
I'm talking about the one right below it. Cannabis tax revenues going into general fund could allocate this more specifically to support higher reimbursement rates and wages for this recommendation.
So you could say a recommendation is to fully explore whether cannabis tax revenue could be leveraged or something like that.
Okay. Then I see below here, it says, I think you had mentioned this last time, Teresa, could recommend that the legislator make targeted increases in alignment with the findings of these studies per changes to the minimum fee schedule.
Yep. That's that comparison rate study.
Okay. So recommend utilizing the comparison rate study. And legislature make targeted increases.
Are SUD now considered behavioral health? I know that we're moving towards that, but the language is still not integrated in many people's minds. So I want to make sure.
Pretty
that
much
when
on our side it is. So I mean, when you look
Okay.
at like so when we say billing or behavioral health, we mean SUD and mental health. We kind of like a
Okay.
both.
Okay.
But yeah.
I just don't know if everybody's gonna know that. Everybody who reads this, you know.
Yeah.
Well, I know in the WAC they changed all the language to say
Oh, did
behavioral
they?
health.
Oh, okay.
Mm.
Okay. Thank you. It's good to know.
Yeah. Just kind of reorganizing some of this language. Although I know it is probably Brianna's job to make it look pretty.
And you're putting that under room and board.
No, you're right. I shouldn't put it. Oh. Far did I go back? It probably could be its own bullet, huh?
Well,
but it's not really like a recommendation. It was kind of it seems to be just as a, what's it called, proof or fact to supporting fact. I don't know. What other recommendations, Beth, would you say we could make to support increased reimbursement rates?
Whoops.
This thing is finicky.
What keeps going through my mind is if you know, if you want people to feel good about continuing to work in a highly stressful environment with complicated people, you want them to be able to feel safe and secure financially so they're not worried about other things while they're at work. You know, like, how can I get a different job to pay so I can pay my bills? I'm not sure how to word that in an appropriate way, but it just is obvious to me that if you pay people better, they're going to work, they're going to want to stay in their jobs, and they're going to be happier. They're going to feel secure. But this part, there's evidence that that proves that if you pay people better, they're going to stay. You know, where to the right terminology.
I say that.
The well-being of providers, support the well-being of providers. That will encourage.
I say encourage the attractiveness of working in this industry. We don't always get the accolades that for doing such a hard job.
Right. There's constant stigma and there's barriers. It's just continuous. You know, I spend so much time, trying to remove barriers for patients, and it's highly stressful. Entering and staying in the field, entering and staying. This needs to alleviate, to somehow alleviate burnout. Because if you have the money, you can go on retreat. If you don't have the money, you're not going on any retreats to replenish yourself, your soul, your body, and your mind.
What's considered, this may be a dumb question, or I should probably know, what's considered a living wage in Washington?
I think that's what median salary indicates.
I think that's what people are getting paid, but what is it where, because I thought I saw somewhere that in order to live comfortably, the living wage in Washington is like 100,000 or something.
Oh, goodness.
Yeah, it was crazy. To keep up with inflation, essentially. I'd seen that.
Yeah.
Can't see that happening. But maybe that was, sorry, that wasn't positive. It should happen. Mental health you know, I think that our wages should be, you know, the same as mental health providers, because we are providing mental health services to very sick people.
Have you seen that, Teresa, what I'm talking about?
I saw a thing, I did, I want to say I saw it on my Facebook feed. And it was the US map, and it compared states, like what the living wage would be in different states. And it was like 100,000 to, like, I thought for a single person, or I can't remember, but it was high. It was like really high. Whereas like right now, I just Googled. Can you see when I switch my screen? Like, are you able to see this?
Yes.
Okay. Living wage calculation for Washington. And it says here, living wage, no children, 25.60 an hour, 2 adults, both working with 2 children.
That doesn't help me.
No, that's what is this on?
I just Googled living
No.
wage Washington. I mean, I'm just like,
That can't be accurate.
it's not accurate.
MIT living wage calculator. LNI might be more reliable source.
Yeah, so one of your comments though could be, instead of putting median wage, maybe we need to be using what's a living wage.
Ah, good idea. Yes.
Maybe like recommend examining. I'm afraid if I say what is a living wage, and they're like, well, a living wage is 55,000, and we are already paying you 77,000, so you guys should be happy.
Yeah, I know.
But they're not paying them 77,000. Median salary for all of Washington employee people, not just behavioral health. Is that median salary for behavioral health altogether? Because
And
mental
that's the
health
thing is,
providers make a lot more money than SUDPs. And if they're, you know, 77 is
Maybe that's
a lot
maybe
more
that's
than
maybe
I've
that's
folks-
ever made.
and folks would argue though that for us in mental health, we need a master's degree.
Right. True.
and so maybe instead of putting median wages, maybe our recommendations is that mental health and substance use disorders be more equitable in salary wages.
There you go.
You could, but then I'm up against a master's degree, 6 years of schooling to do that.
So how do we include without leaving people out, you know?
Right. I mean, I think, I mean, I'm not arguing that the wages don't need to be increased, right? But I'm just saying that we are getting, one of the things that we're considering with the minimum fee schedule is, if we had a minimum fee schedule, we might tie it actually to education or credentials. So if you were an SUDP doing an assessment and you had a master's degree, then the reimbursement rate would be higher than if you were an SUDP with a BA, for example.
Right.
So that's one of the things that could be considered in that minimum fee schedule that they're talking about.
That one's really hard though, because most SUD providers are either in their second career or having coming out of, I mean, most SUD providers are people who are coming from lived experience. And so they have to work in order to go back to school and get the higher degrees.
Yeah.
Which is really hard if you're getting paid a lower salary because you don't have a you don't have a degree. How do
Right.
you manage to live and go back to school in order to further yourself?
Right. Yeah. Would we be recommending other things besides wage increase? I mean, is there other like better benefits, access to childcare? I don't know.
It'd be nice
Paying
if
for
they had.
licensure. Go ahead.
What about? I don't know if this could come from. What about tuition reimbursement for those in the SUD field trying to get a higher degree in order to be successful?
Yeah.
Would that fall onto the employers though? Or would that be like a state grant or something?
I mean, it could be a state funded tuition reimbursement option for SUDP, SUDPs, SUDPTs. I don't know.
I'm a blah blah blah. I could just like blah 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 my sentence all over the place and I'm trying to keep it succinct.
I think you're doing great, and we're basically unpacking everything, right? Trying to get at the nuggets, and you're doing awesome. So I appreciate you.
The note takers, the hardest role. I was like, I was gonna volunteer right away, unless I had to.
They didn't get very far and we only had like 10 minutes.
Well, but I think I mean, like I said, I think this section is the nugget, and the other stuff, no offense, is kind of fluff, right? It's like it's fluffy support, and making the case. To me, this is the nugget. But
There's something that keeps coming up for me is managing caseloads for SUDPs and mental health providers. I mean, if your caseload is overwhelming and constant, that increases burnout.
yeah, it does.
And so is there caseload is it the managing caseload legal recommendations are in some other format, I believe, some other legal documents, wax. But do we need to include that in here?
I was just thinking, and kind of what you were talking about, Beth, is up here we talk about room and board, but residential treatment isn't the only type of treatment we have.
True.
And reimbursement rates for the other
outpatient.
Right, the other type of treatment services are low, and so it is a direct correlation, right? If you're only getting reimbursed so much, you can't pay for another provider, so that provider has to work harder and have a bigger caseload because they can
Mhm.
only afford so many providers.
You're
Um,
forced to violate your own ethics.
So this rate study that keeps getting mentioned, so it looked at both outpatient and inpatient. And so if it moves forward, it will create a minimum fee schedule for both inpatient and outpatient services. So you guys
Okay.
know.
Okay.
and that's down here. Here, wrong one.
But you're right, like they need to like pay staff better to keep them, and then they need to have more staff so that the caseload size goes down to something manageable.
Right.
Um,
Right.
but it's sticky because I'll give you an example. We had 100 million in COVID ARPA funding that we gave out to providers, like lots of money, and we don't really know how they used it.
Yeah.
Once, so I mean, I hope that it went to wage increases. I hope it went to getting more staff, but
Mm,
it's just sticky because you don't.
they
I
paid
mean,
themselves bonuses.
they could have. I mean, I hope that's not what happened, or the CEO gets a fatter salary. I don't know.
Or it goes to facility maintenance, right, which is a high cost.
It is.
Um,
Hmm.
keeping the lights on is a super big priority too, which is getting more and more expensive.
Well,
Exactly.
Super.
I've been looking for a position in various around the Washington state. I've been looking at ads for SUDPs all over, and the wages have gone up, which is
Mm,
really wonderful since
okay.
the last time I looked. Yes, it's amazing. It's much
Okay.
better.
Well, that's good.
Yes, it's much better than it was. And some of it is even equal or more to what I'm making as a navigator at a medical center. So, which is good and is encouraging, you know.
And I think part of that was when they required us to document what we are paying people. I think keeping up with the Joneses is a real thing.
Right, right. They
You
had to
know,
be, yeah, transparent about what they were going to pay you before you apply. You,
yeah,
yeah, they used to not tell you how much you were going to make until after you were in the interview.
after they offered you the job. Yep.
Right. Yeah, I appreciate that transparency.
I always hated that if they don't tell you because it's like I'm not going to waste your time and I don't want you to waste my time. So tell me what the range is.
Yeah.
To me, I think I don't know how to write this, but to me, it's super important when we present this recommendation to show how cyclical this one area is to all of it, right? If we don't have staff to provide care, um,
Oh,
then we can't reduce barriers to access. We can't help the thousands upon thousands of people who are needing treatment um, because there's nobody there to do it. Looks like we have like 5 more minutes. Do we have anything else that I should put in here before we close?
I think that's a lot of very real information and good stuff get us on the right path here.
Isn't that why, Teresa, you may know better than I do, but I think, isn't that why a lot of the detox settings closed, is because the reimbursement rates were just so low that they couldn't afford to stay open? And, you know, that's part of the reason why ERs are so overloaded, is because there's no place else for them to go.
Part of what happened is when we had the BHOs had blended funding, right? So they had blended Medicaid and state funding, and they were able to pay some of those providers, and in general, the facility-based providers, on what is called a capacity arrangement, meaning we're going to pay you whether you have all 16 beds filled, or whether you have 15 beds filled, or whether you have 12 beds filled. We're going to pay you your operating costs to make sure that those beds are accessible. When we went to integration, the contracting structure kind of shifted, and you really, with Medicaid funds, you really can't be paying for no services, right? I can't just pay somebody money and have 16 beds empty, or you know what I'm saying? And so the Medicaid rules were a little stricter, and so they went, a lot of them had to go more on a different contracting arrangement. So what that means is when their census gets low, they lose too much money, and a lot of them struggled and are still struggling because of that. Does that make sense?
Yeah, I was just trying to think of what our recommendation could be for that. I know that this may be out of our realm of ability, but I know that, you know, Fairfax just opened their medical residential, but there really isn't any other place in the state of Washington that somebody who has a significant medical issue can go to treatment. Or sorry, where am I going? Medicare. Somebody who has Medicare can't go to treatment because of the medical aspect of it. Do we know if any conversations have been happening with CMS about taking away that requirement that Medicare can be used at other agencies?
I haven't heard of any recent ones, but I do think it's a gap, a clear gap to maybe call out, and maybe, you know, recommend the state speak to CMS regarding Medicare gaps in Medicare coverage. Because with our aging population, Medicare is definitely becoming more and more, and I think it's a clear gap. And I'm happy to say that the states got vocal a couple years ago about mental health, because they weren't covering licensed mental health counselors, licensed marriage and family therapists. They weren't recognizing, they only recognized the social workers. And so they finally, Medicare finally recognizes a broader range, and they should be recognizing SUDPs. So it's also on the outpatient side too. So that's an issue.
Well, it changed a couple of years ago, but it's still hard to find providers. I'm here to tell you, but I was so happy when Fairfax said they accepted Medicare for patients who were needing detox that are on Medicare.
The reason being, though, is Medicare only recognizes hospitals, like our evaluation and treatment centers, our residential facilities, Medicare won't recognize.
Right. They can't go to inpatient treatment, but they can go to detox. But,
but
at least that was something.
Yeah, but I think that's.
I thought Fairfax changed that they have a 28-day program now for Medicare. but it's only 16 beds. So I know that we have more than 16 Medicare eligible people who need treatment.
Yep.
I know I get pretty regular rehab Medicare coverage, 2 beds. Yeah, so yeah, I'm looking at an email from Canon Syverson at Fairfax. It was Tuesday, that's July 9th. Psych beds 4, ITA, psych bed 6, detox 3, and rehab Medicare coverage 2. So those were the openings that day. So they must be taking Medicare, but not Medicaid for rehab. But they take Medicaid for detox. That's right. But not for the 28-day inpatient, unless it's mental health also, or primarily. Anyway, I was just glad
Well,
Medicare had
So
coverage.
she's given us a warning that we're gonna be probably pulled back to the big group or closed down or something. So just heads up in the chat. She's given us the
Teresa, do I need to do anything, or since this is all shared, I can just close my window?
Yep, I'm pretty sure, because I'm seeing all the changes, so I think, and I've had to